So welcome to our discussion on neuro disorders and neurotrauma. This is the end of our neuro discussion. We've seen quite a bit on trauma discussion. So we've seen overall trauma and trauma principles. We've seen abdominal thoracic trauma, and this will be our neurotrauma. So as I identified previously, this will be the section where we talk about the Glasgow Coma Scale. So let's go ahead and look at our objectives and then move into the content. Quite a few objectives because we're going to be talking about neuro regarding central nervous system or brain, and also spinal cord injuries and some of the complications for everything. So let's move on and start our content. So the main points to the presentation are going to be a lot about intracranial pressure when we look at trauma to the brain or traumatic brain injury. The other issue for brain injury is trending. So especially in the acute phase, we can really want to pay attention to trends of level of consciousness and neurosigns. For spinal cord injury, we'll look at the urgent and emergent care for those patients and also the long-term effects for spinal cord injured patients. So traumatic injuries include, as you see, both blunt and penetrating trauma. You can see blunt could be in a decelerating or accelerating injury. The individual could be hit by something, fall. It could be a motor vehicle or motorcycle accident. Penetrating trauma then directly injures the cerebral tissue. 50% involve the brain, and of the survivors, you'll see a majority of survivors, not a huge majority, but 55%, will suffer from long-term disability. And since many of these individuals are younger individuals, it does take a toll on family, it takes a toll on social and financial repercussions for that individual for the rest of their life. So here's our pathophysiology for brain trauma. Typically there's a primary injury, and you can see due to the mechanical or the penetrating forces, they damage the tissue, they can damage the vessels, and we can have a very mild, such as a contusion or bruise, to lacerations to hemorrhage. There's a secondary injury, however, due to the confined space of the skull and the brain, where different biochemical responses move from the site of injury to the areas around the injury and extend the damage to tissues that were originally not involved in the event. So the ischemia, the high levels of CO2, the low levels of oxygen, you can see a lot of the cellular responses then move to the areas that were not involved in the original injury. So let's take a look at that. So this is the trajectory of a secondary injury. We see there's trauma, and that would be the black area that results in hypoxia or hypertension. Now, to be totally honest, this is a slide of a stroke. So you can see the dark area is the infarcted tissue. And the reason I'm using the stroke image is that it's the same physiology of hypoxia and hypertension in the brain. So you see the dark area is the original stroke. The red area, however, is the secondary injury, and that's, you can see it's quite a bit bigger, and that is due to the ischemia, the edema, the decreased perfusion of the cells in that area due to the increased pressure, hypoxia, and therefore damage. So we've gone from an area of kind of a moderate effect of the injury to a quite larger effect of the secondary injury. So with traumatic brain injury, there are a variety of diagnostic tests to anticipate. You can see X-ray is going to be a good screen for any damage to the bone. We can check for fractures. CT scans, MRI, with or without contrast, will get into the tissue. MRA and angiograms, MR angiogram, that's what the A stands for, or angiography, that'll give us a good data on the vessel and the vasculature of the tissues. Depending on if these are using certain dyes or not, we might have to look for allergies. Then we have EEG and EMG. EEG is electroencephalogram, and that is the, quote, brain waves. So we're looking at the intrinsic electrical activity of the brain cells. And then EMG is an electromyography, which is more related to spinal cord injuries, but for brain injuries too, we can see if there is paralysis, if the muscles and the extremities are affected. And trending is important to see if things are getting worse and your patient is getting more acute. Here's our rapid neuro assessment, and this is typically around the time the patient comes in from the trauma into the emergency department. We want to initiate that ABCD. So the D would be the Glasgow Coma Scale. But if we have a patient and we want to think neurologically, of course we do the primary assessment, make sure they're breathing and circulating first. Move to the Glasgow Coma Scale. And there are a few other things we can look at too. Their pupils are part of this, I believe, are part of the scale. We'll get to that in a second. But do they have pupillary responses? Are they even? Are they equal? We look at the motor exam. If there's a drift to the extremities, I know you've had this before with stroke, with the NIH stroke scale. Alteration of consciousness is very important, and you can see that's one of our earliest signs. And it's also one of our vaguest signs. Is someone, not quite as oriented because they're tired, because they're sick? If they've been in the emergency room a while, maybe they're losing some of their level of consciousness, and it is a big deal. Also, are they really less oriented, or if they're older, are they deaf, or have they not have their hearing aid in at this point? So just good critical thinking. And then for neuro assessment, we look at the history. Do they have a history of headache? Have they had a history of any of those components listed? And then sensory exam. You saw with spinal cord compression as a oncologic emergency that sensory precedes motor. So this would be very important when we have spinal cord injury. And also cranial nerves are important for more of an extensive neuro assessment, because the cranial nerves arise from the brain itself. Here's our coma scale. And it's not pupillary response so much as it is eye opening, so I apologize for that. Higher score means the patient's in better condition. The lowest score anyone can get is 3, because if they're not responsive, they get a 1 in all 3 categories. They can get up to 15 points, which would be alert, oriented, and totally functional. Here are the categories, and you can see a 7 or less indicates the individual is comatose. Now here's a detailed Glasgow Coma Scale. I would anticipate that you would be aware of the components of the scale and what you're looking for, but I would not expect you to, off the top of your head, identify exactly what a 3 for verbal response is or a 2 for eye opening. You would always have the scale with you. If you work with it frequently, then you get used to it and you'll be able to do it. But at this point, I do not expect that level. But let's look at it quickly. Excuse me. Eye opening, you can see from spontaneous. So as you walk into the room, they're looking at you, or they open their eyes right away. Or when you talk with them, or only to pain, or they don't open their eyes. Verbal response, they're oriented to person, place, time, and event. They can give you their personal data. And then we have some confusions, responses down to no responses. Best motor response would be they can obey your commands. This would be, can they do the hold their arm off of the bed and hold it there for 10 seconds? Can they hold a leg up? So they're touch your nose, They would obey all of your commands to no response. And you can see there's a couple, 3 and 2 are abnormal flexion and then abnormal extension. And those are those decorticate, decerebrate. So let's look at those specifically. So these are not good posturing. And posturing, we really look at the arms for that. You can see the legs are kind of extended and internally rotated, but look at the arms for the cue if they're decorticate or decerebrate. So the first image is decorticate. You see the arms are adducted and flexed, so to the body or to the core. To decerebrate, the arms are abducted or away, and then you see how the wrists are rotated out and hand is pointing away from the body. So that is decerebrate. So to the core, and then curled and away is decorticate is flexed in, decerebrate is away. Let's move then to maxillofacial injuries. We'll look at some of the injuries. We have skeletal injuries have a classification called a Lafort classification. You can see the higher number is the more severe. And this is when like an individual's been hit in the face or beaten or in a bad fall or a motor vehicle accident. But you can see the Lafort one only involves like the maxillary arch, and it does run through the nasal bone. If it's a 2, it totally separates the nasal passages from the orbits. So as you look at this going up and up, and finally the Lafort 2 is a craniofacial, and it's possible you could have a Lafort 2 on one side and a 3 on the other side, but this is kind of classic nomenclature. But as these fractures are moving up to the skull, you're also concerned with are the meninges and the dura that surround the brain and protect the brain, are these torn as you get up into the orbits, because that's the base of the skull there. So as we go up, we're more and more concerned about the craniofacial disruption, but we're also concerned about are the membranes around the brain intact? And then the thought behind that, of course, is if not intact, then we would have drainage and we would have a good port of entry for infection. Here's our complications. Also with the nasal and the jaw, do we have good airway clearance? If they've hit their face that hard, how is their spine up in the neck? Are they leaking infections, as we talked about? They do only endotracheal intubation, or they'll do a tracheostomy. There are, in some cases, you would do a nasal intubation, but not here, because you can see all the nasal disruption. And this is not going to heal. This needs surgical intervention. This needs plate screws. This needs jaws wired. So this would be a big surgery for this individual. Here's a few types of traumatic brain injury. The first would be a skull fracture. And it's either open or closed fracture. Open means the dura is torn. So this would need we don't allow that to just hang out. That patient would definitely have the dura repaired. It might need to have some bone removed if there's a substantial fracture. If the bone is removed, then we don't have the bony protection to the brain, so either this person uses a helmet that protects the brain for a while. If it's a smaller area, they just might be careful with it. If it's a large area where they remove a big chunk of the bone and possibly some of the brain, they have to protect that. The other thing they could do with the bone is they would either take it out and freeze it for reimplantation later, or sometimes they have the bone that's removed for the dura repair might actually be housed in the patient's abdomen and connected to their abdominal circulation. It keeps it keeps it healthy. It doesn't have to be frozen. It goes with the patient wherever they are, and when they're ready to reapply the bone and reconstruct the skull, it's right there in the abdomen. So skull fracture, you see in the upper right there, that is a depressed skull fracture. And you can see that big bulge on the outside would be a very large hematoma. So that's what you'd be seeing on the patient. Concussion would be milder. You can see it's an injury. They may lose consciousness. They may not lose consciousness. It used to be concussions were defined as loss of consciousness, and that's no longer accepted. We all know about concussion from sports now, and many of you can probably share stories about like at the beginning of the sports season, they might do a baseline like mental status exam to make sure that if you were to have a sports injury, that they could test you on the sidelines or know right away if you've had some decrease in your mental acuity, which would be concerning, especially for a young person. A contusion would be a little bit more serious because that actually would have some hemorrhaging into the parenchyma. So here's a little more on contusions. Contusions are typically associated with subdural injuries. We'll talk about subdurals in a moment. And you see contusions can also occur in a pattern called coup and counter coup. So let's see that individual striking their forehead on a stationary object. You see the brain shift forward and become bruised or contused in the front. However, remember the brain is free floating, so after the initial injury, then the brain also then rebounds toward the back of the head and may actually have bruising or contusions to the area where it's had the direct injury in front to 180 degrees opposite of it as the brain kind of bounces back and forth floating in the skull. So that would be a coup counter coup. They would notice the bruising or the injury in a CT scan, and you can see the point of impact and then directly opposite. If the contusions are small, then we watch for headache, the nausea, vomiting, everything we talk to family about if we've had someone come in and have a head injury and they're being sent home. So the contusions can be small to large. If it really starts bleeding and increases intracerebral pressure, that would be surgery. Temporal lobe to the side are concerning because there's a very large artery that runs along the side. So those patients are watched carefully every few hours. If there's significant edema and we have this mass effect and intracerebral pressure building up, it actually can lead to where the brain is looking to escape to a lower pressure area, and unfortunately that's the very top of the skull. There's the opening where the top of the spinal cord that moves into the brain, the foramen magnum, and that would be herniation as the brain moves down into there. The patient would not survive that. Let's look at some hematoma nomenclature. We have subdural, and that's below the dural. We have epidural, which is outside and above the dura. So the first one on the left is a subdural. The middle picture is epidural. You can see the dura is kind of pushed down. Intracerebral would be within the tissue, and that's the third visual. And injury and trending is all due to pressure effects from the bleed. So a little more on subdurals. You can see where the blood is accumulating. CT scan reveals it. If it's mild, they're watched. If it is enough to cause concern, then it could be a craniectomy where part of the brain is removed, the damaged part. It could be craniotomy or incision into the brain to remove whatever is the offending problem. Burr holes sometimes are just holes that are drilled into the skull to relieve some of the pressure and allow some of the hematoma and bleeding to escape. So you see there's 3 different forms of subdural hematomas. There's an acute one, and that would cause a rapid development and need rapid intervention. Subacute would be developing slowly over a couple days or weeks. Chronic, you're more likely to see in older populations. They've had a fall at home, and then you'll see a couple weeks later they're hospitalized because they're a little more confused. Their headaches have been mild, they're getting worse. You can see stiff neck, nausea, and sometimes the culprit is the medications the patient's on, if they're on chronic anticoagulants, or even if they're on that daily aspirin. And they would drain the subdural hematoma. They might leave the drain in for a little while, but their big thing for any of these that need surgical intervention would be also to prevent infection. Let's look at a different type of hematoma now, and that's an epidural. And these are associated with arterial bleeds. So these are the ones that are above the dura, and it's more rapid progressing. So you'll see the signs and symptoms. They briefly lose consciousness, and they might be alert and say, "Oh, I'm so stupid, I fell, and how could I do this?" But then they're in serious trouble quickly. They deteriorate their level of consciousness. They might have a severe headache. It is the bleeding from the artery, and the arterial bleeds are much worse. Now, with that being said, if they were to tear a large vein, we would have some of the same issues. It says dilated and fixed pupil on the side of impact. That sounds counterintuitive for like when you think of stroke. But if you think of the tracts that come off the brain, they cross and go to the other side at the level of about the nose. So above the level of the nose, the signs and symptoms are on the same side as the injury. When you get below the level of the nose, then the signs and symptoms are on the opposite side of the body. Treatment, you see diagnosis there, and this would definitely be a surgical intervention. The sooner, the better. As far as within the parenchyma, you can see the different causes there, and the medical managements really depend on the size. Small hematoma, can we be watched? Watch that they're not extending. Surgical, if their intracranial pressure starts elevating. So let's look at the patient who has had cranial surgery. The provider, the surgeon, identifies the surgical route based on the scans they have available, and it's least disruptive to the tissue and then to the function of the patient later. The post-op care focuses on trending, and also complications. So here's some nursing diagnosis. It can affect breathing. Remember, the medulla controls respiratory effect. There's risk for aspiration, there's infection. So these are just a few of the top diagnoses. So for the craniotomy, again, trending is crucial. We look at their level of consciousness, their vital signs, the good neuro exam, labs. We also look at their urine output. We'll get to a couple effects that can be seen from pressure on the pituitary gland, and then that affects the urine output. As far as assessment and tools, your institution will have specific evaluation tools. Don't be tempted to try something else, because otherwise then people are speaking different languages and you're not getting a good handle on the trending. Also be specific in your notations. If you've noticed something that's unusual with a hand or in a certain area of the body, or the patient's getting repetitive, make a specific note about that. The other thing is that if the dura is torn or after surgery, sometimes patients will say, "I've just got such a terrible postnasal drip and my nose is constantly dripping." and have to swallow all the time, it could actually be a cerebrospinal fluid leak. And that you could test for that by seeing if you can get some of the nasal drip to fall onto like a 4x4 or a 2x2 and see if you see a halo pattern on it, which would indicate it's probably cerebrospinal fluid. Or you could check for glucose, which would tell you it's probably cerebrospinal fluid. Here's some medications commonly associated with craniotomies. You can see we've got some anticonvulsants. Now, sometimes they will put a patient on anticonvulsants without a history of seizure because they're at a high risk for seizures. And we really don't want the patient to suffer from that when they're trying to heal. Steroids are maybes, and the more appropriate use for steroids would be with like a primary brain tumor. Those have a good effect for the patient. You'll see that in a subsequent slide if you don't want to take a note on that right now. And then diuretics, they really want to keep the pressure off on the brain, keep the excess fluid down. Antibiotics definitely. Antiemetics are very important because when people are vomiting, that actually increases their intracranial pressure. So anytime that you've been really sick and you've had a terrible headache and you've had to vomit, remember how horrible your headache became right after that. It's because your intracranial pressure rose a bit. And then if their blood pressures are getting too high, we could give, quick-acting IV antihypertensives as needed. As far as incision care, they used to put that big bulky bandage on the head. Now they tend to just have it open so you can watch the site and want to monitor any drainage. If there is any drainage, yellow or bloody, it could be cerebrospinal fluid leak or bleeding. And then just watch all the good post-incision healing. If the bone has been removed and it's significant, they would need a little helmet, and those are specially designed, or they could, and then they would freeze the bone or again insert the bone into the individual's abdomen and kind of like connect it to a vessel to keep it vascularized. The other thing we worry about with spinal cord and with brain injury patients are DVT prevention. So we'd have to be careful to watch for bleeding versus DVT prevention. So definitely the SCDs, they might not be started on Lovenoxes or right away. So we'll talk about DVT also under spinal cord injuries. Some other additional care, so good hygiene, good hand washing, sterile care with the site, good vital signs. You should know by now the signs and symptoms for meningitis. So it'll be headache, fever, that stiff neck, which is called nuchal rigidity, and watch any dressings or drains. Nutritional support and hydration, good intake and outputs, good protein nutrition to improve healing, and as soon as they can begin to take oral and enteral feedings, that's our preferred. We don't want them getting constipated. We don't want them straining and bearing down, because that definitely would cause increased intracranial pressure. So stool softeners and all the interventions as they're getting better to prevent constipation with fibers and fluid. As far as a couple other things we can do that are non-pharmacologic, we can help the patient how we position them to reduce intracranial pressure. So we don't allow them to help, like pushing themselves in bed and turning. It would be, we don't want them, holding their breath and pushing up against the bed as you're trying to pull them higher in bed. We would move them carefully. It is helpful to have the head of the bed up for kind of venous drainage. Also, make sure if the patient can't, keep their head in a neutral position, which would be like balanced above both shoulders, kind of looking straight ahead, not with their head tilted to one side or the other. We want that neutral position. and that helps the veins in the neck from kinking off and obstructs venous drainage. We talked a little bit about fluid management and some of the osmotic diuretics such as mannitol, antiemetics, coughing, try to prevent coughing. We also try to limit the suctioning, obviously if they need suctioning if they're on the ventilator, and then allow the patient time to rest. They can, if patients have like the intracerebral monitors, you can see their pressures go up as you move them or suction them, and that's kind of one way of identifying if the patient's intracerebral pressure is going up. If they don't have a monitor in for pressure, brain pressure, then we have to assume what we're doing is elevating those pressures, and to be careful, group some interventions, allow them to rest. If their pressures are going up, and we can see that on the monitor, we need to do some interventions for that. Here's our one complication about for increased pressure in the brain, especially after surgery or injury. They don't last very long. They are expected after surgery because you have some edema after surgery anyway. But we have two different presentations, either diabetes insipidus or a syndrome of inappropriate ADH secretion. So those are both related to the pituitary, both related to ADH. And if you're trying to figure out which one is which, just think, when we talk about diabetes, we talk about polydipsia, polyuria, polyphagia. So this is a polyuria presentation, and the patient does not have diabetes. So just be clear, they're not going to give insulin. There's nothing wrong with their glucose, but they've stolen the name diabetes because of the polyuria. So large quantities of urine, we have to watch their blood pressure, the patient's severely dehydrated, replace their fluids. If necessary, you might have to give vasopressin, which is the replacement for ADH, to restore the fluid balance. Typically, again, it is self-limiting, and within a few days it's over. But think of all the things you do to assess the patient for dehydration. I'm not going to give you the details on that. If the patient has too much ADH being secreted, then the renal tubules retain the water. So therefore we have concentrated urine, reduced urine output, their serum sodium is diluted because they're overhydrated, and our treatment is fluid restriction. And again, it's self-limiting. Here's some of our complications, our goals for increased intracranial pressure. And we really want to be careful to stave off increased intracranial pressure. We need to maintain a good cerebral perfusion pressure, which is CPP, and it's directly related to cerebral blood flow. So cerebral perfusion pressure is related to cerebral blood flow, and we really want to prevent cerebral damage, ischemia, and compression. Here's our surgical peak for edema, and the treatment is typically to remove whatever damage or masses or tissue that needs to be removed. Frequently, they will place a ventricular drain or some kind of drain because they expect there's going to be fluid drainage from the site. They can use this drain to obviously drain, but they can also use this drain to monitor the pressure on the brain tissue, which is very, very important. So for increased pressure, here we've got a couple of non-pharmacologics. We already talked about watch the patient's position in bed, keep the head of the bed up. But there are a couple other measures that we can do to treat intracranial pressure. One of them would be hyperventilation. So I would like to edit to the PCO2 of 25 to 30. Remember, if we have a range of 35 to 45 with a normal midpoint of 40, the acidotic, it's not the acidotic, the low carbon dioxide actually stimulates vasoconstriction and therefore decreases the pressure on the brain. So although they might drive the PCO2 down, they try not to actually do too low. They might drive it to 30. The reason if we drive it too low, what's going to happen to the bicarbs? Now your kidneys are going to get involved, and we're going to be goofing up the pHs and the bicarbs and the renal function. So they will drive the CO2s down by hyperventilation to get that vasoconstriction and reduce the intracranial pressure. And you can see cerebral blood flow and PCO2 are proportional, so therefore, if they're starting to retain CO2, then we're concerned because the cerebral blood flow increases and therefore more fluid and more pressure on the brain. So that's one maneuver. We can restrict some fluid so they don't have a lot of the excess amount of cerebral blood flow. If they have fevers, we have to treat those right away because that increases intracranial pressure. So they might be placed in a hypothermic state. They might use the drain to drain off some of the fluid and reduce the intracranial pressure. And then there's their bed position and head position. So those are a couple of our non-pharm methods. Some pharm methods, we've talked about some of these. Diuretics, there's a variety of diuretics, mannitol, Lasix. Ethacrynic acid is like a super Lasix, but they usually do the mannitol. And here's our corticosteroid statement. It is effective with surgery post-brain tumor, but is still not quite certain on traumatic cerebral edema. Some neurosurgeons will use that. The one event or one intervention they can do for severe intracranial pressure is to place the patient in a barbiturate coma. And this is for really difficult to control intracranial pressure patients. It says when they're refractory to conventional, that means they're not responding to all the other interventions we're doing to decrease their pressure. So it is a real extreme measure. So they'll use barbiturates and load the patient up on a barbiturate. And this kind of slows down the cerebral metabolism. It reduces oxygen requirements and therefore leading to cerebral blood flow decrease, therefore decreased intracranial pressure. So the patient's family typically is pretty concerned that their patient, their family member was moving around and maybe a little agitated or whatever, but now they're really not responding at all. So the physician will talk with them, but you would have to reinforce this is to help their brain, keep the oxygen requirements down, trying to preserve their brain until they get, maybe you're on this for a couple days, that 48 to 72 hours to see if the patient can improve. Now, it's been used in drowning, especially with kids. Put them in a barbiturate coma, let that brain kind of be quiet, and then pull them out of it. And it does work in some patients. So this is felt to protect the brain cells. The only thing is if the patient is given an EEG at this time, there's no response. It looks like they're brain dead. So we don't make any judgment calls on brain death while the patient is in this state. They would need to wait till all the barbiturates out of their system and then see what's going on as far as electrical activity. So they're comatose. You see the pupils there. They have no voluntary respiration, so they're definitely on control for the for their ventilatory mode. So again, they reassure the patient's family and help them through this time, which sometimes it does help and sometimes it doesn't. No, there's no guarantees. Here's one of the intracranial pressure monitorings. You'll see the pressure. ICP is usually below 15. Usually they have standing orders to drain if it's greater than 20. And as far as monitoring, they do if you've seen any of the monitors for the heart or any other type of indwelling monitors, they have to zero the monitor once in a while to make sure they're getting an accurate reading. So they level the monitor with the transducer and make sure it zeroes out, and then they can get a good reading. So I'm not going to hold you to that maneuver, but if you are employed in that area, you will be taught how to zero out and level the monitors so they're accurate. You can use the monitor to drain because there's like a transducer port which will get the pressure reading, but there's also a drain that you can use. A couple different sites, and it depends where the surgeon is working, what their preference is. So you can see, if you look at the list there, you can kind of figure out where they are. Subarachnoid, intraventricular, and let's look at some of the sites, but you don't have to know that. But you can, if you hear anyone talking about an epidural pressure monitoring, you know where that is, or a drain. So here's the different monitors. You can see a subdural, you can see a bolt, you can see a ventriculostomy, so that's right in the ventricles. So again, it really, it just depends where it lies within the brain as far as the label to the monitor. Now, things really are grim, and they cannot get the intracranial pressure down. The patient, if their skull is intact, they may herniate, which means the lower parts of the brain then move through the foramen magnum at the top of at the base of the skull and the top of the spinal column, and like move into the top of the spinal column, and this actually crushes the vital centers of the brain, and the patient passes away. So you can see a very late sign is that the patient's pulse is slowing, they're getting really hypertensive, and the pulse pressure, the number between the difference between systolic and diastolic is getting bigger and bigger. That's the Cushing's triad. If all of a sudden the pressures go from extremely high ICPs and fall down to 15, you know that the patient has herniated, and this is not recoverable. Let's move to spinal trauma. Here's some statistics, heavily oriented toward males, but women are gaining here as we get to be a little more risky and take chances. Obviously, this is a risk factor for spinal trauma. I have a couple of mechanisms of injury from your text. You can see hyperflexion would be a head-on collision. This is where your chin is like moves quickly to the top of the chest. Hyperextension is a rear end collision. The more common term of that is whiplash. Rotation is the alignment, like moves off to the side. You can see the term axial loading, and that's like compression. This would be someone jumping from a roof, out of a building, like landing. They could land on their legs. They're going to probably break femurs, but if they would land in a sitting position, that would certainly cause compression. And then a penetrating injury. You see a penetrating injury noted to the right there. So with spinal cord injuries, I'm just going to focus on the complete injuries. There's some partial spinal cord injuries that are incomplete, so those are more detailed and more better information for those of you going into like neuro intensive care. So for general information, then you see the term paraplegia and quadriplegia, and you can see where the injuries are typically located. And para would then be paralysis of the lower portions of the body, so legs. And then quadriplegia would be more serious. This is a cervical injury. And you could see arms, legs, trunk. And that's a complete injury, a higher level injury. Let's look at those as in a visual. So here's our para, hemi, and quadriplegia. And the areas in gray are the injured areas. And so para, you would obviously see that in your stroke patients. So again, just a visualization. Emergency care of the spinal cord injured patient is to, if one is suspected, is to not cause a spinal injury. If it looks like something is happening, it's to prevent further injury. So assume any head injury, any spine trauma, or potentially an unconscious individual has an SCI, which is why they're careful not to twist the head or move the patient where there would be potential injury at the neck or in the back. So we have a neutral head position, no rotating, flexing. So sometimes people want to reposition or sit someone up. It's like just leave them be, keep them flat. We don't know if they have a back injury. Spinal shock is that neurogenic shock that we talked about in our shock section. So this would be related to spinal cord damage, and you can see T6 and above is a more severe presentation. So this is a shock presentation that lasts usually about a week. You can see some patients it can last a little longer, but they usually stabilize after that first week and a half. You can see I've got a couple things starred, and that's because this is what we talked about earlier under shock. When they lose that sympathetic parasympathetic balance at that point, they tend to develop bradycardia. So that would be a big hint that this person's had a spinal cord injury. Also hypotension. Now we don't know if they're bleeding too, but definitely the bradycardia. If they're bleeding, they should be tachycardic. And if they're bradycardic and it's symptomatic, we have our magic medication you'll need to know, which is atropine. Bowel and bladder dysfunction, as you see, but we talked about before, they have inadequate thermal regulation. They're very warm, dry, flushed skin because they get that vasodilation and they're losing a lot of heat. They also have the febrile episodes and loss of sensation below the level of injury. So again, a couple of these points are just review from our neurogenic shock discussion. Here's some acute interventions. So again, we have to watch that hypotension, the vasomotor instability. If they have this vasodilation, their pressure is going to drop. They might need IV fluid resuscitation. Head of the bed though needs to be flat. Remember, they might be on a board as well. They might come in with some compressive devices, or we might be using some form of SCD to move their blood to the core. If it's a high cervical injury, they're going to have to be intubated because they're not going to have control of their respirations. And then thermoregulation, make sure we've got warm blankets for them. If their temperatures are all over the place, they might need antipyretics as well. So surgical interventions to anticipate, they could do a couple things. If it's a spinal cord injury and they just need a laminectomy. I think you've had these before. So that lamina is kind of a padding in between it's like a disc in between the bones. So they might remove that and decompress that, pull out any fragments that might be pressing on the cord, get that out of the spinal canal and fuse that in place. They can fuse to prevent motion, to protect the spinal cord. They can actually insert rods into like the wings of the vertebrae to stabilize the spinal column and protect the spinal cord. So you would do all of your typical post-operative surgical care plus good neuro checks on this patient. There's some immobilizing devices they can use. They can use skeletal traction. I've got that in another visual. They can use a kinetic bed where they're basically flat in bed, but the bed rotates so they can like stand up, replicate standing upright or laying face down. For a patient that's more mobile, they can actually, you can see this individual in this picture is able to get up and move around. So they've had a spinal column injury, but I would say their spinal cord has not been damaged. So the halo traction brace would be for ambulation. So you can see these are high fractures. And with those, the little halo that's on their head, they actually do have that attached to the skull. And then they probably would have the cervical vertebrae either fused or surgery on it to immobilize that. And then during the healing time frame, they would use this brace to make sure they're not moving their head. If they do have like thoracic injuries, they obviously are going to be on flat bed rest. They can use body cast, braces, jackets. I've got a picture of a jacket on the next slide or two. Here we go. So I'm sorry, this is a cervical traction where they use weights to kind of keep the patient's neck in line. A neck immobilizer, you can see the person's head is in alignment here, and this is like a soft brace. For thoracic, the braces would be a little bit, bigger to encompass the whole chest and keep the thoracic area aligned. We have a couple non-surgical interventions for spinal cord injury. They do use steroids, and they try to use those fairly quickly. There are some places that are actually injecting this into the spinal column to get the steroid directly to the spinal injury. There's some cardiovascular pharmacologic interventions. They can use, now Isoprel is a drip that can be used for bradycardia. So this is for a critically ill patient. They can use the vasopressors for hypotension, but they could also use atropine if the patient requires atropine for the bradycardia. Others, if the patient has a spinal cord injury, their GI system is going to be quiet for a while, so they might have an NG tube to suction, Foley catheter, and then we talked about thermoregulation as well. A couple nursing diagnoses to be aware of. It depends on the height or the location of the spinal cord injury. The higher we go, then we're more worried about respiration. We're worried about cardiac outputs. We also have like skin integrity because they're not able to move as well. Nutrition, sexuality, and lots of information on moving forward and recovering and rehabilitating and kind of being as active as possible with a spinal cord injury. If high enough, then we have to worry about gas exchange. So all the good things about gas exchange that you learned, watch the trends. They do need to be on a C3 and above as a ventilator because they can't control their respirations. And, you know, the typical ventilator function, ventilator care. For cardiac output, we have to watch for good cardiac output. We can't give them too much so they, you know, fall into pulmonary edema, but we have to combat the hypotension. So they might be on cardiac output and CVP monitoring devices for a while. They might be on inotropes to improve their cardiac function and their cardiac output. They might be on vasopressors to maintain their blood pressures. So everything we learned previously about cardiac output. As far as mobility and skin integrity, they might, if they have a high enough injury and their hands are involved, they might need range of motion. They might need exercises to prevent contractures. You can see foot drop prevention. They could certainly use boots or splints. Some patients for foot drop, they just recommend getting like high top athletic shoes, like the Chuck Taylor shoes that can support the ankle. Those sometimes are cheaper than the custom-made boots. Hand splints, due to the impaired mobility, we have the DVT prophylaxis, remember those, and then skin breakdown. So good assessments, good skin care. They might need a specialty bed while they're critically ill, and then good nutrition to make sure that their protein and carbohydrate or calorie intake is meeting their needs. Elimination. As far as bladder elimination, when they're acute, they use a Foley catheter, check their I's and O's, but afterward, some patients with spinal cord injuries will choose to use a Foley catheter with a leg bag. Others would prefer just to catheterize themselves every 4 to 6 hours, and they're taught how to do a clean catheterization. And bowel programs, too, we don't want them constipated because that can produce a very serious, dangerous adverse effect called autonomic dysreflexia, which I have slides on later in the discussion here. But everything for normal bowel movements tend to prevent constipation. Body image is a huge issue. What are your patients' expectations? Who were they previously? Are they going to be able to adapt to their new body image? So there might be a lot of anger, there might be a lot of depression, there might be even suicide expression. So lots of good referrals to social service. There's support groups that are very helpful. Letting the patient talk and be angry is okay. And helping the patient identify how they want to move forward too. Nutrition. They might have total parenteral during the acute phase because their GI system is usually quiet at first. If it's high enough, we have to do a swallow assessment. Here's our high protein, high calorie diet. So, you know, good proteins, meat sources, vegetable sources, peanut butter, eggs, milk, yogurts. Think of all the good snacks and dietary supplements too. This might be the ensures and the high protein supplements, adding the fiber for the GI, and then daily weight to make sure their nutrition, they're meeting their nutritional goals. Sexuality. So we have a couple concerns for men and some for women. The higher the injury, the more normal the sexual function, which sounds weird. But the sexual arousal in the male is only related to a reflex arc. So it's stimulation, then the stimulation goes in as a reflex arc into the sacral area, that part of the spinal cord, and then the response would be the erection. So if that area has gotten the injury, that would make the male impotent. So in a male who has suffered a spinal cord injury, they can still have an erection, but they have to be stimulated. And there are some different methods for stimulation that a couple can be taught about. There's some implants and other devices. Women, their big thing is they cannot, they may not feel arousal or orgasm, but they can definitely become pregnant. And individuals that are pregnant and spinal cord injured individuals are high-risk mothers because they cannot tell if they're in need of attention. They can't tell if they're starting into labor early, if they're miscarrying, if they're having a problem. So these are high-risk moms that need specialized care. Here's our acute complication, and that is called autonomic dysreflexia. And this is a very sympathetic, life-threatening sympathetic response. So it's a visceral stimulation, and it happens after that acute spinal shock is over. So this is patients, they've had their spinal cord injury for a while. This has to have immediate intervention, otherwise they get extremely hypertensive, can stroke. So we have some possible causes. Again, it's visceral. So if their bladder's distended, if they're impacted, if they have severe pressure ulcers, even if the patient is compacted and then they're trying to disimpact the patient, that can cause this. Here's, again, our high-risk mother, uterine contractions, bladder dysfunction, bladder stones, so all kinds of possible problems from dysreflexia. So it is some kind of visceral, painful stimulus below the level of the injury. We get this acute sympathetic response. Therefore, they have rapid heart rate, tachycardia, vasoconstriction, extremely high blood pressure, scary high blood pressure. So symptoms, sometimes the patient just says, I just have this horrible headache and I feel hot. They know something is going on, especially if they've had this before. Nasal congestion, you see this nausea, all from the hypertension. So the first intervention is to kind of quick assess the patient. You're going to be calling the doctor potentially, so what is going on? So it would be, like, put the head of the bed up a little bit. Let's see it, check the vital signs. We want to try to find the cause and remove the stimulus. So it says here a possible intervention is catheterize the patient. So if you have a patient who has a Foley catheter in, you might notice there's no drainage. It's like, uh-oh. Then it might just be that the catheter is kinked. If it's been that way for long enough and the bladder is distended, now you have a problem. If you can determine their bladder is distended and they don't have a catheter, yes, we need to catheterize the patient. So the big thing is to try to get the blood pressure down. So I guess I'm going to back up and say, elevate the head of the bed, take the vital signs, and then treat the hypertension as quickly as possible, and then try to determine the cause and get rid of the stimulus. So if it's bladder, fine. If they're constipated, we have to deal with that. Call the physician, obviously, while all this is happening. This is probably going to be you're going to be calling on your team to help with this. So we really need to get the pressure down immediately, so that would be your first intervention. But very dangerous for the patient. Let's go to a little bit of discharge planning after your patient's gotten over their acute phases. There are a lot of mobility devices that are available for the patient. The house might need to have some ramps and grab bars and some devices moved in, safety measures in the house. If there's lots of stairs, they're obviously going to need to stay on one floor. You can see they're going to need help with ADLs, and the severity of their injury identifies what that's going to be. And you can see some of the other points to discharge planning. We've got some devices I want to show too. So this is difficult. It's difficult on the family. It's very difficult on the patient. Do they have the insurance and the backup to have people come in and help? Is this going to be just one person helping, or is there good social support for the patient? And here are some adaptive devices. You can see if they're able to move their upper extremities a little bit, there's ways they can feed themselves, do their teeth. There's some reachers you can see. It's hard to see them because they're small. And then there's a little buttoning and unbuttoning devices. They're devices to get socks on, and a lot of patients want as much independence as possible, and they're not going to be able to get dressed in 5 minutes anymore. But to be able to dress and feed yourself is I think a big goal of a lot of patients. So at this point, I believe we're at the end. Yes, we're at the end. So that was our trauma. That was our neuro and spinal cord injury, both brain and spinal cord injury. Our last discussion will be on burns, and I do have a little bit on end of life. I don't think I'm going to have you include that in the final exam, but I will let you know. So at this point, again, be careful. Have a good day. Hope you're all well. And I look forward to one more voiceover PowerPoint, and I also look forward to chatting with everyone in our Blackboard Collaborate. So I'll see you then. Have a good one.